Good evening to all. Good evening to all the seniors and the faculty, international faculty from Germany. It's a great honor to be convening this CME on a very good topic. I welcome all the international faculty for the CME. I hand it over to Dr. Varghese sir, President of AMASI, for a brief introduction of this.
Thank you, Dr. Dagaji. And welcome to all to the online CME series of AMASI, which is conducted every first Thursday of the month. And this program is going to be the 13th program, and this year the first program. And this so special about today's program is that we are conducting today's CME in association with the German Association of Minimal Access Surgery. And we are honored by the presence of the president of the association, Dr. Christoph Woodstein, here as a moderator. Welcome, Dr. Christoph. And then Dr. Stefan Benz as the speaker of today's CME, and will be talking on the right hemicolectomy. And apart from that, we have our moderators, Dr. Prakash Kurumbur is there, and then Dr. Ramakrishnan from Adayar Cancer Institute, Chennai. And I think Dr. Ramchandran will be joining shortly. He hasn't joined so far. And I'm sure that today's session is going to be very interesting. So we eagerly look forward to your talk, Dr. Benz. And before handing over to Dr. Deboshi and Jagdish back, I request Dr. Pallivellu sir to say a few words.
Thanks, President Varghese, and I'm very happy to be part of this program. And this is I'm eagerly waiting to listen to Stephen, and he's expert in colorectal, and also the moderator of President of Minimal Access Society is my friend. I'm very happy to be part of this CME program. This program is going very well. I'm enjoying it every time when I participate, and happy. And wish all Happy New Year, and we'll start the program. Thanks, Varghese. You can start. I'm eagerly waiting to listen to Stephen.
Dr. Deboshi.
Good evening, everybody. Welcome on behalf of AMASI to the first program of the year. As Varghese said, it's the 13th of our series. First, I'd like to announce the winners of the quiz of the last CME, which was held in December. Both of them get a gift check of 5,000 rupees. We have two winners. We have Dr. Kamar, who is a final year surgical gastroenterology student from Government Medical College, Salem. And we have Dr. Madhuri, who is a PG student in Delhi. So these are the two winners. Do we have them link on the here? Dr. Madhuri, Dr. Kamar, are you here? I think they have not joined. We have informed them, and they are supposed to become members of AMASI, and then they receive the certificate as well as the prize. It's my honor to move on to the next program. Next part of the program is the quiz for today. Quiz for today, which you are supposed to answer within the next few minutes. If somebody can show the quiz. It's an MCQ quiz. It is related with the topic for today. What are the risk factors associated with colorectal cancers? Risk factors of colorectal cancers, including which one of the following is the most commonly involved. That is what is the answer. You have to write A, B, C, D. Either one of them. And you have got 30 seconds to read this and 5 minutes to answer this. Whoever answers this the fastest will get the answer. We'll have another quiz question, which will be just after the lecture by Dr. Stephen. I hand it over to Dr. Jagdish for the rest of the program.
Yeah, good evening to all. Please allow me to introduce the three moderators. Professor Ramakrishnan was not sent the link. I have sent the link now, so he'll be joining shortly. To introduce Professor Christoph Woolstein, is a special expertise. Is one of our moderator. He has a special expertise in visceral and general surgery, surgical oncology, and minimal invasive surgery. A special interest in oncological, minimal invasive, and robotic surgery, and improving techniques in minimal invasive surgery. Example: right hemicolectomy. I hope I'm heard, sir.
See lecture
With CME and minimal invasive pancreatic resections. 1996 to 93, he did his medical school at Ruhr University, Bochum, Germany. Please excuse me my pronunciation of Germany words, Professor Christopher sir. 1993 to 2000, training in general surgery in hospitals at Ramstedt, Hamburg, Rostock. And he did his doctoral thesis in 1997. 1999, he did his board certification in general surgery. 2001 to 2002, he was a senior physician, Department of Surgery, University Hospital, Bochum, Germany. And 2002, he did his board certification in visceral surgery. 2002 to 2008, he was a senior physician, Department of General and Vascular Surgery, Johann Wolfgang Goethe University, Frankfurt, Germany. 2004, Vernier Legend, thesis, risk factors of morbidity in clinical simultaneous pancreatic kidney transplantation in uremic type 1 diabetic patient. Since 2008, he is the director of the Department of General, Visceral and Minimal Invasive Surgery, Helios Hospital, Krefeld Teaching Hospital of the University of Aachen, Germany. Memberships in executive boards in professional societies, a surgical working group, minimal invasive surgery, CAMC, Germany Association of General and Visceral Surgery, chairman since 2021, and member executive board since 2015. Surgical Association of Surgeons in Northern region in Germany, and chairman in 2002 to 2023, and vice chairman from 2023 and 2024. He is convention of surgical chief physician in Germany, advisory council of the executive board since 2018, and has various memberships in professional societies. Welcome, Professor Christoph sir. We look forward to your moderation. And we also have Dr. Prakash Kurumbur. His skills are in minimal access surgery, laparoscopic and robotic colorectal surgeries, pancreatic surgeries, Whipple's, open and distal pancreatectomy, major hepatic resections, research and publication. He is the current leader, senior consultant in GI hepatic biliary surgery at Aster Medicity, Ernakulam. And 2003 to 2015, he has been chief of gastrointestinal surgery, PVS Memorial Hospital, Ernakulam. 2002 to 2003, he was a resident for the diploma of AFSA Hospital in Paris, in France. He did his AFSA, Bijom Hospital, hepatectomy, pancreatectomy, and liver transplant hospital in University of Paris. And he's a Master of Surgery in Surgical Gastroenterology of Medical College, Trivandrum. Master of Surgery, Baroda, MBBS from Trichur. He has 36 index publications, 4 texted chapters, and operating faculty in Ware, and is a very good person and excellent colorectal surgeon. Please allow me to introduce Professor Ramakrishnan. He is a professor of surgical oncology of GI and hepatobiliary cancer surgeries from Adyar Cancer Institute. He has 75 journal publications, 2 book chapters. He received various grants for research, including the UK Academy of Medical Sciences, Global Challenges Research Networking Grant for study in microbiome in colorectal cancer, and DBT India Alliance Team Science Grant for study in early onset colorectal cancers, besides multiple travel grants for UICC and ICRET Fellowship. He has special interest in colorectal cancer and peritoneal malignancies, on clinical research methodology and quality of cancer. He is an excellent surgeon, excellent academician at one of the best teaching cancer hospitals in Tamil Nadu. I hand over to Dr. Prakash for next step.
Good evening, everyone. It's my pleasant duty to introduce today's speaker, Professor Stefan Rolf Benz. He is the professor and head of the Department of Surgery in Clinical Boblingen, Germany. Sorry if I am not spelling it correctly. He has completed the medical school in University of Tübingen and University of Hamburg, Saar, Germany. He got further trained in Memorial Sloan Kettering Cancer Center, New York, and in Hospital Continental de Freiburg, Switzerland. and he has completed his graduation and fellowship FMGEMS in 1991. So his clinical experience starts in 1992, where he has joined University of Tübingen, Germany, and further in Department of General Surgery and Transplant Surgery, University of Rostock, Germany. He became professor of surgery in University of Freiburg in 2016, and since 2014, he's the head of the Department of Surgery, Clinic in Boblingen, Germany, where he is currently working as professor. He has worked in German Colon Cancer Foundation 2008, and he was president of Association of German Colorectal Cancer in 2009. And in 2017, he was vice president of Association of German Colon Cancer Centers. And he is a member of many professional organizations, and he has numerous publications. To name it a few, he was the principal investigator in the prospective multi-center trial on CME on the right colon cancer, the RESECTAC trial, and he has many publications in the current topic, which he is going to deliberate today. And I think without wasting much time, I invite Professor Stefan Rolf Benz to the CME. Thank you.
Yeah, thank you for that very kind introduction, and try to share my screen. It's really a big honor to give this talk for the together this sort of joint venture of the AMASI and the German Society of Minimal Invasive Surgery, and I think this should not be a single event, and I think I see a lot of potential in working together and learning from each other. So my topic today is a minimal invasive right hemicolectomy with CME D3, topic I've worked for the last 15 years in. And I start with sort of definitions, because people are talking about CME D3, and some try to make differences out of it. I give you my take. So in 2009, Professor Hohenberger published a complete mesocolic excision. And what he said, or his definition, was that this was a complete excision of the lymphatic drainage, and importantly, the preservation of the integrity of the facial envelope. So all the package together. Professor Hohenberger never made a difference between CVL and not CVL, so central venous ligation. That was something actually the publication, from the publication side, from the editors, was more or less put in, but for him, CME is CME with CVL. What the extent of resection is depicted here. So it is the entirety of the ileocolics, the anterior surface of the vein. Also, he clears the anterior surface of the artery with sparing the nerves. And then the right branch of the middle colic artery, and that's the resulting area of lymphadenectomy. Now, when you go to, and this is probably, so the definition was a narrative one. It was not by sort of strict anatomy, was sort of described in the article. In opposite, the D3 dissection of Japanese type was something which was the definition strictly is related to the definition of the lymphatic of the lymph nodes along the main or along the vessels, and the D3 compartment along the superior mesenteric artery. The lymphatic the compartments are defined according to the arteries. The veins are really not mentioned in the definition. So not like in the superior mesenteric vein is not really a landmark in the definition, although the Japanese surgeons look for it. And also the gastroepiploic nodes are part of the definition if thought to be or are considered to be should be resected for if mesogastric structures, so the omentum or the splenic or the flexures are involved. You can see this in this operation site where the lymph nodes are marked because of an ink injection. The ileocolics here, that's a right colic artery, and you see this is the D1 compartment close to the bowel, D2 compartment around the mesocolic window, and the D3 along the artery. So there's a short video sequence. You see the superior mesenteric vein here from that patient. That's the mesocolic artery, and these are the D3 stages: ileocolic, right colic, and middle colic artery. Now, what are the data? I want to start with the data from Japan. These data are derived from a registry, so it's not randomized. You see only a slight divergence of these survival curves, but if you look at the hazard ratios, there is a considerable benefit for D3 compared to D3 in these early results. Now, currently one of the best data come from Anders Bertelsen from Denmark, also not randomized, but he has they have a very good coverage of a registry, or I have to say 100% coverage of the registry of Copenhagen, the capital of Denmark, with 4 hospitals, and it's only him who does the CME, all others don't. And these are the results of these 4 hospitals, and you see that the CME, at least after the learning curve is passed, is a bit sorry. It's in favor of CME, not so much, and it's only borderline significant. But if you look at the recurrence rates, they are considerably higher in the non-CME, whereas the death rates due to non-oncological reasons are pretty much the same. And if you look at the numbers, especially in the stage 3, there is a cut to half of the recurrence rates from 34 to 70%, and this is significant. Now, we have published our study last year. It's a multi-center study done in 43 centers in Germany. We had a pre-planned endpoint disease-free survivals after 5 years, and we thought that CME would improve prognosis after R0 resection combined in stage 1 to 3. We included 1,004 patients. Registration recruitment was between 2012 and 2016. Follow-up 15 months. And we also didn't randomize for the reason we can discuss, but we defined a CME if the superior mesenteric vein was dissected, and if was not dissected, we defined it was a non-CME. This criterion was not known by the surgeon, so there was no to avoid bias. All specimens were shipped to one single center, pathology center in Germany, and I just show you the survival curves. We didn't meet the primary endpoint, which is combined stages 1 to 3. So there is only a sort of a 4% improvement for CME. No difference in stage 1, no difference in stage 2, but there is a there is a 13% advantage in stage 3, and this is statistically significant also after all kinds of adjustments. The problem was the editor, because the primary endpoint was not met, the editor sort of forced us to conclude that there is no difference. However, if you look at these curves, if you know the biology and you know the data before, it is quite clear in my mind that we see a benefit in stage 3 for CME. And this is also what this meta-analysis shows for stages 2 and 3. There's a clear benefit in stage 3 in that quite recent meta-analysis, which does not include our study still. If you think of including the study, then this benefit in stage 3 will even increase. So I think we have a clear benefit in stage 3. The other stages, I think we don't know. And because we don't know the stage preoperatively, and CT clearly does not help us, molecular biology neither, I think it's reasonable to do a CME in patients with right-sided colon cancer. So in Germany, we started a project in 2016. It was we called it the expert group laparoscopic CME. And our aim was to safely implement CME for right-sided hemicolectomy in Germany. The steps we wanted to take is easy understanding of the anatomy. So because we thought and knew that people, or also us included, just don't really understand the anatomy at the central aspects of the mesenteric root to do the operation safely. So this was the first thing. And then we tried to create a clearly structured procedure with steps, and the steps concluded by critical views, just like the critical views known for a laparoscopic cholecystectomy. So you really have one view you have to reach before you move on or do a irreversible step. We developed this in the Institute for Anatomy in Kiel. So we're doing cadaveric dissections, and published our work 2018 in surgical endoscopy here. And one of the most important basis of understanding anatomy was the development of the open book model, which you see here in this drawing. Open book model means that the mesos, so the mesocolon, the ascending mesocolon, the transverse mesocolon, the mesogastrium, are all reflected by or represented by book pages, and the book is sort of has the back is the axis of the pancreas with the gastrocolic trunk of Henle here included. And the important thing is that we now really can assign all these vessels to the mesos, respectively to the pages, and we can and therefore we can talk about going sort of left or right to the of the page, and clearly naming our procedures. So what you see here, gastroepiploic vessels in the mesogastric page, the middle colic vessels in the transverse mesocolic page. And a very important vessel here is the superior right colic vein, which sort of which runs in the mesocolic page, but somehow bridges the gap between these two pages a bit, and runs here in the gastrocolic trunk of Henle. And if you exert traction here on the superior right colic vein, it really it tears out, and you have the bleeding. That's why it's also called the bleeding point vein. And the gastrocolic trunk of Henle is sort of anatomically sort of complicated, because the veins from all three pages do merge here together from the pancreatic head here, the stomach, and of course the mesocolon. And so these are the pages I've just explained. And advantage, the cloud now can clearly assign the vessels to the pages. And to make it a bit more easily, I just removed the transverse mesocolon page here, and then the area around the Henle trunk gets a bit better into view. Superior right colic vein can run into the Henle trunk from here all the way up to here. And if it's up here, it's of course, if you tear a bit too much, it can easily bleed. It's also of note that the gastrocolic trunk of Henle is not resected, because if you resect, you have to sort of divide the pancreatic vein, the gastroepiploic vein, and all the small veins running dorsally into the pancreas. And this makes or puts a higher risk of bleeding. So it's really important to know about this anatomy. The middle colic vein runs into the superior mesenteric vein by definition, and normally is not resected in a CME D3 right hemicolectomy. We created, Christoph Stray created this animation video where you can still see the different pages, pancreas, and the booklet, which is sort of the axis along the Henle trunk. So I think it should, yeah. And it's really this situation we have to consider, that we separate the mesogastric structures from the mesocolic structures, and have this sort of view before we divide the vessels. And this is the situation of the superior right colic vein that may easily tear out. So the principle of the operation and the arrangement of the steps now is that before we divide the vessels in the mesocolon, we open the book. We separate the pages. So we open the book before we divide the vessel. If you're a perfect surgeon and know it's all by heart, it's no problem. You can do it in a different way. But this is, we think, the easiest way of understanding the operation. Another important thing is understanding the facial envelopes of the right colon. And this is depicted in this section. This is sort of the embryological stage, let's say after 2 weeks or so. What we see is the colon with this peritoneal coverage. So it's the visceral peritoneum on the anterior and the dorsal posterior side. And the peritoneum running also over the pancreas and the duodenum. But then we also see the parietal peritoneum, which is gets here attached to the colon and the duodenum, and which encloses the Fredier space, which obliterates, of course, in the further course. An additional fascia, however, is the anterior renal fascia, is Gerota's fascia. So that's the third player. So we have now anterior renal fascia, we have the parietal peritoneal fascia, and we have the mesocolic fascia, which used to be the visceral peritoneum. So it's three fascias, and they can separately and deliberately be addressed. So you can separate parietal peritoneum from visceral peritoneum. This is opening Fredier space in a medial to lateral fashion, and this is what's done in the medial approach of a right hemicolectomy. If you lift the ileocolic vessels, open the space underneath, and then push your way in a medial to lateral fashion, you will open Fredier space from here to the lateral bowel. But you can also do a renoparietal dissection. So this is sorry, is somebody talking? This is the way you do it in open surgery. You go lateral to the colon, lateral to the white line, work your way down, and then you reach the dorsal side of the duodenum, and then you lift the whole right colon up, and you will see the duodenum sticking on the mesocolon. So this shows you that the parietal fascia is still intact. And so if you want to do a CME, you have to, after the first mobilization, you go anterior to the duodenum and then open Fredier space. So you first go behind, and then you enter a Fredier space in the central part. And this gives a nicer macroscopic appearance of the specimen. And the same thing can be done if you start your dissection below the duodenum, as we do it, as uncinate first approach, or you also can do a infraileal approach. You go slightly behind the duodenum, mobilize the whole way in a medial to lateral fashion, and then also secondarily, as I will show you in a minute in the video, enter Fredier space. But this leads to the situation that the parietal fascia remains on the tumor and on the mesocolon, and gives it a more rigid and firm appearance. So this is what I've just shown, showing this publication of the working group of Thilo Wedel, which we were also part of. And all what I've just said, you can see in these cadaver specimens the three levels: anterior renal fascia, parietal peritoneal fascia, and the mesocolic fascia. And Jordan Fletcher has also made an animation where you can see that it's a link which is online, so you can play around with it and have a look at the different fascias. Now, what is the operation like we have designed? I told you about the critical views. First, the ports and the positioning of the patient. If we do it laparoscopic, Lloyd-Davies position. This is the ports. I use more or less two 12-millimeter ports, 5 here to retract the stomach. And for intracorporal anastomosis, we use a Pfannenstiel-Schnitt, and the camera is mostly here in the suprapubic position. For robotic, we use a primary suprapubic incision for the pneumoperitoneum, and for robotic trocars as you see it here in the cystrocar through the Alexis retractor. We have to redock because we start in head down, tilted to the right position. And the first step, which is for some people a bit astonishing, we start at the fourth part of the duodenum. So we move the whole small bowel in the right upper quadrant, expose the duodenum or the duodenal jejunal flexure, and incise the peritoneum just dorsal to the duodenum, and then follow this plane to the hepatic flexure, and of course mobilizing the whole ascending mesocolon. And the first critical view is then here, basically the third part of the duodenum together with a pancreatic head. And as I said, the Fredé space is here already opened. And this is the area you can mobilize from this point. So this is what you see on the robot. Again, here up here the situation, we start down here at the duodenum, the aorta, the inferior mesenteric artery, and then we dissect very gently the plane directly dorsal to the duodenum. So directly here dorsal to the duodenum. So down here, this is anterior renal fascia covering the cava and the ureter and so on. And then this is all anterior renal fascia. This is the peritoneal parietal fascia. And this is, and you see, it used to be called Toll's fascia. We called it Toll's fascia, but now it's much more precise saying parietal fascia. And this is open now, here, very precisely and deliberately. And then you enter this space. So this is the step of opening this fascia here. And then you see the pancreatic head. That's then Fredé space. And this is critical view 1. This is already the superior right colic vein here. So pancreatic head, such as said, and then open the peritoneum down to the cecum. Mobilize it a bit on the laterally already. That's the ovarian or testicular vein. So this is the first step. Then we put the patients in head up, left down position, and retract the terminal ileum to have traction on the ileocolex. This is called, and that what we want to see is the V-shaped configuration between the ileocolex and the superior mesenteric vein. And then we incise in between, so not close to the ileocolex, because we want to excise the entirety of the lymphatics here. We don't want to destroy the lymphatics along the vessels. So we enter the mesocolon here. This is not that difficult to, or the orientation is not that difficult because we've already mobilized the dorsal side. So because according to the open book model, the page is already mobilized, we go through the mesocolon and then have our orientation, look for the superior mesenteric vein, and then work our way up until the base of the mesocolon. So that's what you see here, ileocolex, superior mesenteric vein. And from the mobilization, there's a slight hematoma, and we would start incising here. Thereafter, the both ileocolic vessels are isolated at the origin. So we go 360 degrees dissection around these vessels. These are critical views number 3 and 4. And here you see in the video the V-shaped configuration, ileocolex. That's the peritoneal window. So we have a distance to the ileocolic lymphatic drainage area. We go through the mesocolon. It's it's already free down there. So we'll enter that space in a second, retract it upwards, and then you have a quite nice orientation. You do see the cava, the duodenum, and the pancreas down there from the first step. And that's the duodenum. So it's already free, and you only have to care about the vessels. In that case, the superior mesenteric artery is right to the superior mesenteric vein. We'll show you an example at the end where this is very prominent. And then you can work your way up, and you can do the lymphadenectomy in that area without having trouble for orientation, because it's already lifted up and you know where you are. So that's the superior mesenteric vein. In that case, I didn't go too much to the arteries, not the way I showed you in the first very short video sequence. And then the artery is here sort of peeled out. And then we work our way to the ileocolex. That's critical view number 4. Artery is 4, and the vein is 3. In that case, I just use these metal clips. The vein, I think it's really very important to go around 360 degrees. Otherwise, you will run into trouble at some place if the vessel is only half closed or something like that. That's a ileal vein coming here, and yeah, and then you can follow the lymphadenectomy here. So then you would think, yes, just follow the superior mesenteric vein and go for the middle colics. But if you remember what we said, we first want to separate the pages, open the book, and then go for the vessels. In that sequence, we have to go into the lesser sac, so opening the gastrocolic ligament, somewhat right, somewhat left to the midline, and then separate the mesogastric or the mesogastrium from the mesocolon. So the first landmark would be the dorsal aspect of the stomach, but also preserving the gastromentals, and then separating mesogastrium and mesocolon in the avascular space. What we now want to see is the so-called sulcus view. So the sulcus between the mesocolon you would see here. So the mesocolon and the mesogastrium. This is what was earlier called the intrapyloric lymph nodes with a gastroepiploic vein here. So gastroepiploic. This is the superior right colic. The right colic, and here would be the superior mesenteric vein. And the dissection line would be along here. So we preserve the gastroepiploics, but divide the superior and the right colic vein. So that's the video, dorsal aspect of the stomach. And then you have these this avascular plane between mesogastrium and mesocolon. One always has to take care not to divide the colon. And then you jump over the duodenum and follow the plane and the division line to the right hepatic flexure, or to the hepatic flexure. You normally encounter already the dissection, the dorsal dissection plane from the first step. These are the infrapyloric lymph nodes, so the mesogastrium, which is dissected away from the pancreatic head, to get to see the veins running from the gastroeploic vein running into the Henle trunk. That's the duodenum, and the last attachments from the duodenum to the mesocolon. Now you see here, let's see exactly this this view: mesogastrium, right gastroeploic veins, superior right. Yeah. So then we go for the vessels. So we flip the transverse mesocolon cranially, and then dissect the right branch at its origin of the left, or at the branching side. So it's retracted upwards. We see a vessel in the mesocolon. If you don't see a vessel, you just go perpendicular right anterior to the superior mesenteric vein, and everything to the right of this line normally can be divided, but of course you have to look for the vessels. This is a rather small vessel. You normally quite easily enter the open lesser sac because we've already divided, we've opened the book, and the right branch of the middle colic artery is normally encountered probably 1 centimeter anterior to the superior mesenteric vein, and very often you don't really anticipate it until you really see it. So this is quite a strong one. Yeah, can be a metal clip or a robotic clip, but that doesn't make much difference. And then you see the Henle trunk here, and in the next sequence, the Henle trunk is the important landmark. We dissected at the origin of the superior mesenteric vein, and then follow the Henle trunk on its anterior surface, and everything which runs into it from caudally and anteriorly can be divided, and the lymph nodes respectively are resected. So critical view number 8 would be the anterior surface of the Henle trunk, as you see it here in the video. Pancreas, superior mesenteric vein. There's a lymph node close to the Henle trunk, which I wanted to resect. So with a robot, you can do that rather delicate resection without injuring the pancreas. And in the end, the superior right colic vein remains, which is then clipped, and this concludes the central dissection. So we do an intracorporal anastomosis, which I just flipped with a stapled and 2-row hand-sewn anastomosis of the common channel. Now, if you look at the specimen of this operation, especially on the posterior side, you see this very smooth surface here, which has a sort of solid appearance, and there you see the cutting line of the fascia of this parietal peritoneal fascia along the duodenum. So the duodenum would lie in there, but the tumor is covered by the fascia, and so there is really a nice coverage. We have proposed a classification of specimen quality in respect to anatomical landmarks, which you can see here. So a full complete specimen would have the ileocolics, the middle colics, and the window in the middle. So the window has a complete frame, vessel, and this would be the surgical trunk of Coyot, which contains the D3 lymph nodes. If the trunk is open, the surgical trunk is open, it's a type 1. If the middle colics are missing, it's a type 2. And if hardly anything is left like this, it's type 3. One last aspect is that with complicated anatomy, it really can be helpful to have these complete 3D reconstructions. Also, although it's not too sometimes not too easy to keep the orientation. So this would be the ileocolics here, and these are the superior mesenteric vessels. And what you see now is that the superior mesenteric artery is way right of the superior mesenteric vein. And I actually only saw this after the operation. And I just want to show you as a last video the situation. So we enter the space, the V between the ileocolics and the superior mesenteric vessels, and then I look for the vein. And I feel already there is something. I see the artery, but there is no vein. And I follow the artery. That's the ileocolic artery, but there is no vein. And only in the very end, when the ileocolic artery is divided, you see that the vein is coming up here. I think in the last sequence, a couple of more clips, but now you see, just in a second, you will see down here, you can anticipate the vein, and there it is. So this was really a bit tricky, and I think in these cases, these reconstructions, now you see the veins, this can help. So in conclusion, I think that we can say that current evidence really suggests that there is a benefit for CME D3 in stage 3 colon cancer, and that because I didn't show that the morbidity isn't higher in CME compared to non-CME, it is justified to perform a CME in right-sided colon cancer. The critical view and open book concept facilitates the implementation for laparoscopic and robotic right hemicolectomy. It's crucial to understand the retroperitoneal fascia for a safe and optimal oncological operation. And before implementation, I think teaching is really mandatory, and classification of the specimen really helps for quality control. So this is the end. I thank you very much for your attention, and I'm very happy to take your question and discuss with you.
Jagdish, we'll have the quiz question first. We move on to the discussion part.
Yes, sir. Yes, sir.
Can we have the second quiz
So
question?
can you stop share, please, so that I can share the question?
Dr. Stefan, you have to stop sharing your slides.
Okay, sorry. Yeah.
Here we have the second question, which is what is the most important prognostic factor for rectal cancer? Involvement of the nodes, the size of the tumor in length, the histology, the type, or the location, which is the most important prognostic factor for rectal cancers. You have another 5 minutes to answer this. These questions are made for the level of the postgraduate students in surgery. So I think you can answer that within the next 5 minutes. This will be visible for the next 10 seconds, I think. Thank you. Over to Dr. Jagdish and Prakash for the rest of the session.
Thank you, Professor, for your expertise and clarity in conveying complex anatomy and the steps in right hemicolectomy. I request Dr. Prakash and Dr. Ramakrishnan and the professor to moderate the session and clarify any doubts.
Professor, it was an excellent talk, and the open book concept was quite easy to understand. Probably it helps a lot in teaching. I have one doubt. Say, suppose there is a tumor close to hepatic flexure or proximal transverse colon. How how the dissection is going to be different in such a situation in terms of CME and in terms of lymphadenectomy, in terms of removal of nodes close to the gastroepiploic vein? Is there any difference and compared to an ascending colon tumor?
Yeah. So the question is, what is different for a hepatic flexure tumor?
Correct.
Yes. In that case, we take the gastroepiploic arcade from the point where we enter the lesser sac, and then we resect the gastroepiploic vein down to the Henle trunk. So the Henle trunk is still left in place, but the gastroepiploic fat body, so the infrapyloric lymph nodes, are resected en bloc with the specimen. Of course, it's a bit more difficult to keep track of the anatomy because you don't have this nice avascular plane on the pancreatic head. And sometimes it's a sort of a quite wide area which you have to dissect away from the pancreas, and you might encounter pancreatic tissue in the fat of the mesogastric fat pad. So you really have to be careful, especially when you divide the gastroepiploic artery. There might be pancreas that can be injured.
Understood, Professor. Thank you.
Dr. Stephan, this is Dr. Ramakrishnan. Thank you for a very simplified way of approaching CME with D3 dissection. I have a couple of technical questions and also a more theoretical question. If I may ask you, the first critical view you said was looking at the duodenum and the head of pancreas. And you said you would approach it from the by an uncinate process approach. Now, is this the only way that you can achieve the first critical view, or can you not do that by a bottoms-up approach, mobilizing the ileum from below upwards? That is my first.
You can. I mean, it's not the only way. Instead of starting at the duodenum, you can start at the medial part of the medial or medial to the cecum, sort of. That would be the infraileal approach, and work your way up to the duodenum. In that case, you just don't know whether you've anterior or posterior to the parietal peritoneal fascia. You don't know whether you hit the duodenum sort of from the front or whether you go behind. I mean, this is something that doesn't make that much difference, and I know a lot of people do that because they feel more comfortable with that. From a theoretical point of view, starting at the duodenum makes you sure to the position according to the fascias. I think it's very important to start from below, either infraileal or uncinate first, to have these first dissection. So the first page of the book is free before you do the lymphadenectomy along the superior mesenteric artery and vein, because you have defined your borders below the duodenum, the pancreas, the retroperitoneum. You see all that. So if you haven't done that in the first place, people tend to sort of slide to the side and then leave quite a lot of the lymphatic tissue along the superior mesenteric artery and veins in place.
It's interesting that you were mentioning that the parietal peritoneum also needs to come with the specimen. How much importance do you place to this step of taking the parietal peritoneum along? Because then you don't enter into the threaded space, do you?
Yes, you do. You go secondarily into 3D space. I mean, it's the way. If you do the specimen in this technique is exactly the same as in open CME. In open CME, you take the parietal peritoneal fascia inadvertently. I mean, we haven't known that at that time. But it's always if you mobilize the right colon, you get behind the duodenum. It's just the normal way.
So, other than the aesthetic value of having a good-looking specimen, does it add to an oncological value also?
We don't know, but I mean, we know that there are lymphatics right below the mesocolic fascia, and there is the mesocolic fascia is only one layer of cells of mesothelial cells. It's very, very thin. It's a theoretical thing, but it's sort of following the principles of open CME, and it just looks better. Whether it transfers into, I mean, sometimes, I mean, you have tumors that invade even Gerota's fascia, and so I think for some tumors, yes, there might be a chance. And I think if you're able to have a deliberate choice, it's always an advantage.
What would you assume to be the learning curve for?
Didn't get the last one, but I think it's a matter of how intensively you're willing to deal with the anatomy. We do a lot of courses, and people get really nice specimens in their first try in these courses. And what we see is that older surgeons who have not, intensively or not intensively devoted to right hemicolectomy, they have really difficulties in investing the time. It's a matter of patience and time you want to invest.
The other point I was wanting to know was in your paper, the prospective study, also in the recently published short-term results of the Chinese CME study.
Yeah.
The one point that was common to both was a slightly increased incidence of vascular risk. And you were mentioning the bleeding point, that is a superior pulling vein where it gets attached to the trunk of any. So, can you give some tips on what precautions to take to prevent the?
I mean, as you said, the bleeding point, I mean, the coining of the bleeding point comes not from CME. It was called the residence vein long before CME was thought about. So it was actually a phenomenon encountered for people who were not the subtle people dealing with right hemicolectomy. And then you don't know where you are. If you make a small hole in the SMV and you put a sponge in it, normally nothing happens. And I mean, my suggestion or my recommendation is very trivial. Just do it slow. I mean, I need normally about 3 hours for that. I'm not fast. And I look twice before I cut, and I normally try to make the holes or the scissors only open it so wide that I can close the hole which is caused by it. And so I mean, this is the only trick I can recommend.
And finally, a theoretical question. We would assume that the benefit of D3 lymphadenectomy would be if we were able to remove positive central vascular nodes, which otherwise would not have been removed would be less than a D.
Yeah.
My question is, how often have you found positive nodes in the D3 specimen? And would removing positive nodes there actually improve the survival of it?
Yes, as we have in the, if you look at overall, I mean, stages 1 to 3, it's about 5% central nodes. If you look at stage 3, it's something like in D3 specimens. So in CME specimens, it's about 16%. And yeah, it's about 16% in CME specimens in stage 3. So it's not that rare if you have a stage 3.
And
The problem is you don't know before.
So there was a question. So how do you choose in which to perform D3 for all colon cancers? One of the questions in the chat. Do you need to do a D3 for all colon cancers? Right-sided.
We actually do it, yes. The problem is, and there are the data at the moment are unequivocal. You just can't tell. I mean, there are D1 N1 cancers, quite small, highly aggressive cancers. And in these patients, a D3 dissection is normally not a dangerous operation. So if you only do it for a large hepatic flexure tumors, then you might run into trouble because you don't know how to do it or you don't have the experience. And I have to go to this phone. Hallo? Ich rufe gleich zurück, ich bin gerade in einer Diskussion. Ich melde mich gleich. Okay.
All right. So you're saying that at least to get used to the whole procedure of D3, it is better to keep all colon cancers.
Yes, more or less.
I don't see any other questions in the chat box. Yeah, there is one. So then will you be harvesting more than 12 nodes as a routine? I think in your prospective study, you had mentioned that the minimum number of the mean number of nodes was around 50 plus, wasn't it, for a D?
In the prospective study, we had a mean number of about 50, and also in non-CME. I have a picture of a specimen I've just shown you with the ink, with the stained ink, and of looking at this specimen, you can count 50 lymph nodes. So it's mainly a question of the patients of the pathologist. Of course, you have to remove them, but in a normal colon resections, there are right-sided, there are 30 lymph nodes straight away without doing anything special.
So then that leads me to another technical question. So do you think, at least in the future, use of ICG would help choose patients who actually require a D3 lymphadenectomy?
So I don't think, and there are data that we will use ICG to sort of find the lymph node, dig it out, and look for it, whether it's involved or not. I mean, then, to say it bluntly, we screw up the specimen. We shouldn't do that. What is probably more attractive is to look how is the flow of the drainage. So which vessels do we have to remove, or can we spare, let's say, in a hepatic flexure tumor, the middle colic or the left colic or so. And the data look much better, but still there is, I think the sensitivity is still only 70% or so. So we would really we would need higher sensitivity, or probably combine methods that we really can rely on it. And we also have to be careful not to remove too many lymph nodes, because it always shows you more lymph nodes. And normally they're not involved. I mean, those who are outside the normal lymphatic drainage areas are normally not involved.
There's another comment on the chat box that probably D3 is more beneficial for T3, T4 tumors. Have you done any analysis based on the T staging?
There are quite good Japanese data on this. And yes, in average, it's the case. But there is still, I think, there's 15% or so. There are stage 3 in T2 tumors, and then you have the same phenomenon. So I think it's all depends on the same morbidity. You shouldn't produce higher morbidity in CME than with non-CME. I mean, that's the absolute prerequisite that the principle works. And then I think at the moment, unless we have other means of differentiating between the stages, you do it in all stages, and probably we get some means, then we can probably differentiate.
Any other questions?
I think final few comments by Professor Christoph or Professor Palnivelu, sir.
Yeah, Stefan, thank you very much for your excellent presentation. I guess we all again learned something new about the CME, and I would like to thank this time for Amasi for joining, or for doing a cooperation with our German Association of Minimal Invasive Surgery, the CAMIC. Thank you very much. It's an honor for us to join your event. Stefan, I'm not aware if CME is commonly used in India. So if one wants to introduce the CME in his own practice, do you think it should be done by learning the whole, or introducing the whole procedure? Or do you think a stepwise approach could help it to introduce it if you do not have the possibility to have a tutor or something like that?
So before Professor answers, India, it's being regularly done, sir, by many, including Professor Palnivelu, Ramakrishnan. CME and CVL are done regularly, sir.
Yeah, I've talked to a lot of CME surgeons, Indian CME surgeons in the meantime. So I think there's it's a country which is very advanced in that respect. I mean, I think it's hard to have only to do steps or to. The first step when you do a CME is going for the superior mesenteric vein. Otherwise, it's I think you can't approach the problem without thinking about how to deal with that. And yes, of course, it's important to have somebody to teaches you. And you can that helps you and to do some proctoring, but actually today the possibilities are so much better than 20 years ago. Today we have all kinds of videos from all over the world, from the best surgeons. You can look the videos. We have courses. There are books on it. There's a lot of theory, and I think the most severe mistake is always not doing enough theory. I mean, we have to stick to theory first and know everything that can happen. and then we can approach it.
Quick comments by Professor Palnivelli, sir.
Stefan, wonderful. I enjoyed your entire talk, the way the anatomy you described step by step, the book open book form. I enjoyed it. Very nice and a very clear video, and shown step by step that approach. And it is a good learning for all the surgeons. Huh? Yeah.
Okay. I can't say.
Yeah, we will make. I'm going to also make it one like you. No? I mean, we have not seen that. It is a good concept. Nicely has been shown. No, very nice. And beginners understanding the anatomy and the approach, it looks very nice. And I think overall everybody is very happy the way Ramakrishnan and Prakash, all of them, they ask their own clear doubt. But I think it is nothing to ask questions. By comment, I enjoyed it. And Sivan, I saw you also do interested in hernia, it seems. Huh? And and March, we are going to have a minimally invasive hernia surgery program here. I think all of you can take part from there online and will be very happy. And here two questions that Ramakrishna asked you about the inferior mesenteric approach to this. That answer approach we've been using last almost 20 years. And once open the peritoneum, we go in between the gyratosis fascia and this easily. And I recommend it mainly particularly obese people or something there. You put protection ureter, we can identify there itself, starts from there going, may be useful. And the other ICG, I think you said what I disagree with you. But one step future with the research is going on, not confirmed. ICG tagged chemotherapy, in case if it is RO, takes care of well. But if it is not RO, resection, it is R1, the remaining lymph nodes taken care by this tagging chemotherapy to those nodes. And that is, we are still under evaluation, it is going on. And we are doing it, that part research with my colleague. Let us see hopes of future, not now at this stage. And probably that ICG, some people using it for vascularity purpose. From my point, we don't. Easily the vascularity can be assessed. And that way, I think, I don't know whether you recommend that for vascularity assessment before anastomosis, because you also said intracarpal anastomosis you do open, no? And all those cases we do intracarpal anastomosis. So that way, I think today, very good CME today. All of us enjoyed very nicely and very happy about it. And I think, Christopher, I think you're seeing you after many years. I'm very happy to be with you. And German Society and Amasi should go together in future programs. We'll coordinate and we'll do that. Very nice.
Absolutely. I think we can really benefit from each other very much. And I really enjoyed the contact with Indian surgeons now that I've been to Vapi very, very much. So it's really, I mean, there's so much, I feel so much enthusiasm for surgery as not in very many other countries. People are really devoted, and that's great. I love that.
Thank you, Varun. Very nice. And I think, I think Varghese and Roshan will be sending you the link for 18th, and some of you please to contact so that we can have a workout for future programs like this.
Yes, very good. Yeah,
great idea.
Yeah. Hand over to Gaborshi. Yeah.
Can I ask a question?
Yeah. Oh, President is still waiting to ask a question. Yeah, go ahead.
No, Dr. Stefan, you always remain to the right of the superior mesenteric vessels. Anytime do you go to the left of that?
Yes, actually, in the first very short sequence I showed you,
yeah,
I normally go to the left of the superior mesenteric vein. I don't want to push people to do that regularly. I think the standard should be the vein should be free anteriorly, and the rest is add-on. And there are some cases where you go after the nodes of the at the stem of the middle colic. But I wouldn't recommend that doing on a really regular basis.
Right then, if there are no more questions, I think we had very engrossed session today, and all said and done, the technique of the open book technique which he showed to it, which has impressed all of us. I like to. It's my honor to put the vote of thanks. I thank the speaker for that, the amount of effort that he has done to come up with this lecture. I also thank the moderators, starting from Dr. Christoph, Dr. Ramakrishnan, and Dr. Prakash, and along with that, Dr. Jagdish, who was the convener with it. On behalf of Amasi, we have some announcements to be made, and along with that, as we would like to continue the association with the German Society of Minimally Invasive Surgery, and we have the upcoming 100 skill course in Coimbatore next week, from tomorrow, which is on the 5th, 6th, and 7th. And beyond that, we have our MRC Lens, which is coming up on the 18th of January, again on Thursday from 3 to 6 p.m. It starts in the afternoon Indian Standard Time. And we have got some upcoming good big programs like the MRC East Journal Conference in Kalimpong, the Hernia Carnival in March, and ultimately the MRCCon in August. So we have our Wisjon conference also in between, and numerous programs of the Smart Center. I hope all of you will get this information in our mrc.org website, and we hope to be together again in our next CME program. Thank you all. Thank you very much.
Thank you.
Thank you.
Thank you.
Stephen, very nice.
Thank
Look for
you.
you.
Okay.